All right, good afternoon, everybody. Thanks for joining us this afternoon. My name is Greg Stahl, and I'll be your moderator today. So before we get started, please note that everyone should be muted at this time. Also note that American Sign Language interpretation is available. Search for interpreter stubs, hover over the three little dots in the window, and lock it in place. Also note that while we have an hour set aside for today's media briefing, we'll conclude when there are no more questions from the media. So we're going to hear remarks today from Director Dave Jepson, State Epidemiologist Dr. Christine Hahn, and State Laboratories Bureau Chief Dr. Christopher Ball. I'll now hand it over to Director Jepson.
Well, thank you, Greg, and thank you to all of you for joining our press briefing today on COVID-19. I am pleased to share that today, crisis standards of care have been deactivated for Southwest District Health, Central District Health, and South Central District Health. This means that crisis standards of care are no longer active anywhere in Idaho. The Crisis Standards of Care Activation Advisory Committee was convened this morning to review the current situation. As a reminder, the committee is made up of hospital administrators, healthcare professionals, and the state agency representatives. The committee recommended exiting crisis standards of care due to the combination of lower numbers of those being hospitalized for COVID-19, along with a stabilization in staffing and blood supplies. It is important to note that healthcare systems across the state are still very stretched, with many using contingency operations, which is one step below crisis operations. This means that it will be some time before healthcare systems return to full normal operations. While new COVID cases are declining, I want to emphasize that the number of new COVID cases remains very high. And while we have seen a decline for 2 weeks in the testing positivity rate, it is at 25%, which is higher than at any time during the Delta surge late last year, and 5 times higher than the target of under 5%. We are not out of the woods yet. I want to emphasize, as I have for many months, please choose to get vaccinated. It is the best way we have to turn the tide with COVID-19. In particular, getting a booster shot is key. The other way we can stay healthy is to wear a mask in indoor public areas. As a reminder, the Department of Health and Welfare and the Idaho Office of Emergency Management are making free KN95 masks available to the public. KN95 masks have gone to 40 community partners in both rural and urban areas of the state who have made them available to community members. I'd like to thank those community partners who have volunteered to distribute these free KN95 masks. You can call 211 or contact your local public health district to find the location of KN95 mask distributions. In addition, federal partners are making over 400 million N95 masks available for free at selected pharmacies and community health centers across the country, including Idaho. And with that, I will hand it over to Dr. Hahn.
Thank you, Director. Can you hear me okay?
I can.
Great, thank you. Yeah, today I wanted to focus today and talk a little bit about immunocompromised people. We continue to get questions from the media and the public that indicate to us there is some confusion for people out there. So I wanted to really focus on some special, kind of pulling together some of the recommendations that are available, but might be confusing for people who have immune compromise. So first of all, what do I mean when I talk about moderately or severely immune compromised for whom these recommendations are created? These are people who maybe have cancer and they're on chemotherapy. They may have received an organ transplant and still be on immunosuppressive medications. Maybe they've received a stem cell transplant and are still on immunosuppressive medications. They may have a primary immunodeficiency, so something they were born with in which their immune system isn't normal or fully functional, and they are on medical care for that reason. They may be someone with HIV who is not on treatment yet, or is not has not been on treatment long enough for their immune system to be healthy and robust. And lastly, for many people, these are people who are on steroids or other immune suppressing medications for conditions such as lupus or rheumatoid arthritis or other conditions for which sometimes these type of medications help tamp down the autoimmune response that is helping drive their condition. So for those people, we wanted to make sure that they were aware of some of the special recommendations to make sure they stay healthy during COVID. First of all, I want to mention social distancing, which of course many of us have been doing. But for people with immune compromise, they may be aware, but that even if they're vaccinated, it is possible those vaccines are not going to perform as well. Their immune system may not be able to react well to a vaccine. So they should consider taking special precautions, continue to wear masks, for example, even if others in their community are no longer doing so, continuing to be careful about going out into crowds, that kind of thing. Secondarily, I want to talk about vaccines and monoclonal antibodies. And I have a graphic to show, but before I show you that, I just want to mention, just to kind of emphasize that additional doses are recommended of vaccine for immune compromised people. This has definitely been a source of confusion that we've heard about. And as you'll see in the chart that we're going to show, for some of these people, yes, they may need 4 vaccines in order to be considered fully up to date and protected from a vaccination standpoint. And that seems like a lot, but it is because their immune systems are not responding as well to the vaccines, but additional doses have been shown to be beneficial. And in addition, as you'll see, Evusheld, one of the monoclonal antibodies that we've talked about before that is for immune compromised people, is recommended. So I'm going to go ahead and ask if that graphic could be pulled up, and then I'll just kind of walk you through it. Thank you. So what this graphic tries to show is on the left-hand side, you can see for folks that got the Pfizer vaccine, the Moderna vaccine, or the Janssen vaccine, and they are moderately or severely immunocompromised, as I've described. What do they need? First of all, the most important thing to note is that their primary series of vaccines should be 3 doses, not 2 doses. That's a big difference. Everybody hears so much about 3 doses or 2 doses, and then for them to have to go an extra one, that's just a difference. Note that for Janssen, initially it was considered a 1-dose vaccine, and that was great news. But it is now recommended that people who got Janssen get an additional dose. I don't know why the terminology is different from 2nd dose, but essentially consider this a 2-dose vaccine now. That 2nd dose, that additional dose, in addition, should not be with Janssen, but with one of the mRNA vaccines. Lastly, I'll talk about boosters in this population and Evusheld. So after completing the series, everyone is recommended to get a booster dose, but as you may recall, just a few weeks ago, CDC said, really don't wait 5 months. Immune-compromised people should get that booster dose at 3 months or thereafter, just to avoid a long period of time in which protection may not be adequate. And after vaccinations are finished, at least 14 days after the last vaccine, consider Evusheld. When I talked about monoclonal antibodies a few weeks ago, I mentioned that supplies are very limited. That continues to be the case, but we are finding, talking to our healthcare providers, that they've been able to offer Evusheld to most of the patients in the state who were in our first highest priority groups, people with cancer who were on chemotherapy or people who have organ transplants. Those folks are still eligible, and if they're hearing this message and haven't received Evusheld, we still recommend they go talk with their provider about getting a prescription for that product. But in addition, we are now making this available to people on steroids or other immune suppressing medications. So that's important that people are aware that that is now available. Lastly, if you are not sure if you fall into one of these groups, please do talk to your healthcare provider about whether an extra dose of vaccine or whether this Evusheld monoclonal antibody might be right for you to protect you as best as possible. With that, I will go ahead and turn it over. I think Elke is next. Am I right about that? Or
Dr. Ball is next.
Dr. Ball. I'll turn it over to Dr. Ball.
Great. Thank you, Dr. Hahn. I've been asked to speak a little bit today about the progression that the state has undergone with building of testing infrastructure. And since it's been a while since I've talked with you, I thought I'd just kind of recap from the beginning. So as you may recall, at the outset of the COVID-19 pandemic, the state was really focused on building up rapid, high throughput diagnostic testing so that we could identify patients very quickly. And so we spent a lot of time, effort, and worked with a number of partners to build out our PCR-based testing strategies. And as the pandemic has progressed, we've also seen the introduction of antigen testing, which has made diagnostic testing much more convenient and readily available. Sort of the second big part of our infrastructure build out happened in 2021, and that was with the advent of our SARS-CoV-2 whole genome sequencing program for variant detection. And so now we have multiple facilities that are contributing whole genome sequences to identify new variants of concern entering the state and tracking the dynamics of variants as they change through time. What I really wanted to focus on today was the third big plank in our testing infrastructure, and that's taking a look at community level testing through wastewater sampling. So wastewater testing typically consists of sampling wastewater treatment plant influent, what is the material coming into the wastewater plant, or large facility discharge lines, so large facilities that are discharging wastewater into a sewer shed. And this sampling typically occurs 1 to 3 times per week. The testing is done through PCR, but the testing is a little bit different than what we do for patient diagnosis. This is what we call quantitative PCR, which means rather than giving a positive or negative result, a quantitative PCR result will show the number of copies of SARS coronavirus 2 genes in the sample. So over time, when we look at these copy number trends, they can give us an estimate of the abundance of SARS-CoV-2 in each sewer shed or coming out of each large facility. And what we've observed through looking at other sites that have been doing wastewater testing is, in general, there seems to be a positive correlation between the SARS-CoV-2 gene copy number and case rates, meaning that as the wastewater gene copy numbers increase, we also see increases in cases. In many instances, what we see is the wastewater gene copy number will increase and precede that case count or case number increase by approximately 4 to 6 days. So it may provide us with a little bit of a sneak peek of things that will be coming down the pike. So in Idaho, wastewater testing has been conducted in a limited number of communities. Many of you may be familiar that the city of Boise has been doing wastewater testing for quite some time now. So the Division of Public Health and the Bureau of Laboratories has taken some of our COVID response funding and used that to provide subgrants to Idaho's institutions of higher education. So we have subgrants with the University of Idaho, Lewis and Clark State College, Boise State University, and Idaho State University, who in conjunction with the Idaho Bureau of Laboratories will be establishing, or have established, I should say, 5 regional laboratories to expand the number of wastewater testing locations in Idaho. So building on capacity that was developed early on in the pandemic at both the University of Idaho and then later at Boise State University, these 3 new laboratories at LCSC, the Bureau of Laboratories, and Idaho State University will be coming online soon and testing additional Idaho facilities. We'll be using kind of a hub and spoke model, and so far we have nearly 30 sites with representation from every public health district that have expressed interest and agreed to participate in this statewide wastewater testing program. I'm happy to announce that our first data from the University of Idaho has just been submitted and is being reviewed by the CDC's National Wastewater Surveillance System, a system called NEWS. And more sites will be added in coming months as these laboratories start testing additional locations throughout Idaho. The hope is that this data will help us monitor COVID-19 activity at the community level rather than at the individual level. And this is because we're seeing an increase in the use of rapid antigen testing and a decrease in the number of reportable tests being tracked by the state. So it's possible that with the increase in wastewater testing, we should see some early warnings to help guide our future public health efforts and get information out to communities as we start to see gene copy numbers increase. So with that, I'll turn it over to you, Elke.
Actually, I will take over from there. Thank you, Dr. Ball, and thank you, Director, and thank you, Dr. Hahn. So we'll now take questions from the media. The protocol is to raise your hand in WebEx or type your question into the chat area. When I say your name, unmute yourself and announce your name and media outlet before asking your question. Please clear your hand when you're done. I'll do my best to take your questions in order, and I see 3 all at once right now. So I'll just start at the top. Audrey Dutton, please.
Good afternoon, Audrey Dutton with the Idaho Capital Sun. My question has to do with hospital transfers. There was an app that was developed last year, and I think it went live in the fall around the time of the last crisis standards. And I'm wondering how hospitals used it and whether they were able to use it during this surge, whether it was helpful, like just hoping you can kind of tell us a little bit about how that might have changed this crisis versus the last one.
Yeah, thanks, Audrey. I can take that question. And Elke Shaw-Tulloch here, the Administrator for the Division of Public Health. So yes, the app that you're referring to is called Alert Sense, and it's an app that we made available through our Medical Operations Coordination Cell work that we're doing with all the hospitals across the state. And it was actually, was and continues to be very useful for hospitals as they look to try to find locations to transfer patients. It was, it's been useful across all of the different surges since it's been developed. And so essentially how it works is a hospital will kind of tap their healthcare providers or the healthcare resources closest to them. If they can't get a response that way in that closer circle, then they can go through the Alert Sense app that can sort of then extend that request out concentrically from that hospital to the partners around, and then eventually they can rapidly then ping that message out to all of the hospitals across the state. So it comes through as an email, as a text message. So it's that rapid alert system that has very limited details, essentially laying out what the request is for. And then they can immediately get responses back from whatever facility is available. And so it is still being used. And I do want to just express that, you know, I'm incredibly appreciative of all the hospitals agreeing to stand up this system and use the system. It's been very helpful in making sure that patients are taken care of immediately and they have responses immediately. And it's been a really amazing and wonderful cooperative relationship across all the healthcare systems across the state.
And it's only for Idaho hospitals, right? So if they wanted to coordinate with across the borders, they couldn't.
That's correct, Audrey. It's right now available for the hospitals within the state of Idaho, but there are ways that we can still use that system to then work with the other systems that other states have. So some of those hospitals already have natural relationships for those transfer requests. And so that will be part of that inner concentric circle that they have. And then when that can't be met, then they can go out to the rest of the state. So it does allow all of those different systems to be able to operate together.
Okay. Our next question will be from Heather Ann Wagner.
Hello, this is probably for Dr. Hahn, but can you go over the vaccine schedule for Johnson & Johnson for non-immunocompromised people? Because I'm thinking if some got the original shot and then got the booster, is there anything they need to do now?
Right.
Yeah, thank you, Heather Ann. Oh, I'm sorry, Elke.
That's all right, go ahead.
Yeah, I was going to say, I know we have Sarah Leeds on the line, and I don't know if she wants to talk about that. Otherwise, I'm happy to help out. But Sarah, do you want to talk about Johnson & Johnson?
Sure. And I just want to make sure I'm clear on the question. It was for the use of Johnson & Johnson, the schedule for non-immunocompromised. Okay.
Correct.
Okay. So there's been so many changes. I always want to look at something to make sure I'm correct. But it's a 2-dose. You get your Johnson & Johnson vaccine, and then there's a recommendation for a booster dose at, oh my gosh, I'm going to have to look. It's either 2 months or 3 months. But Dr. Hahn, if you know, please chime in. But otherwise, I'm gonna make sure I'm correct and then put the answer in the chat.
Yeah, Sarah, while you're looking it up, because it is nice to have a visual reference for it. You know, it's essentially a similar. So people that got Johnson & Johnson the single dose are recommended to get a second dose of vaccine. It's not like, I don't really like the way they're wording it. Most people are saying essentially Johnson & Johnson should now be considered a 2-dose vaccine, but I think they're avoiding that terminology because that's not the way it was approved by the FDA. So it is considered an additional dose, and it is, and as you probably are aware, it is recommended that that additional dose be an mRNA vaccine. Then there is still a recommendation for a booster in that population 2 months later. So essentially what I showed you for immune compromised, to my understanding, is exactly the same for non-immunocompromised as far as for Johnson & Johnson. The only difference between immunocompromised and non-immunocompromised really is that 3-month versus 5-month interval for that booster dose among the mRNA receiving population, as it were. And the other thing, of course, the little points that I didn't have time to go through on that infographic, which is I have to thank our team, our communications team, for putting that together just today for us when we decided this was critical to have a visual, is that of course, for children, they can still only get Pfizer product. And for adults, though, it is recommended, even for non-immune compromised adults, that they could consider switching product or stay with the same product. So if you got Pfizer, you can go to Moderna for a booster and vice versa. But mRNA vaccines are preferred over the Johnson & Johnson product, essentially. And I think, as Sarah can chime in, we are using less and less of the Johnson & Johnson product now, and there are very few people. I think only on special request are we even releasing any Johnson & Johnson anymore for somebody just starting the series. Maybe somebody's had a severe allergic reaction to an mRNA vaccine or something. But Sarah, I'll turn back over to you to fill in on that.
Yeah. So it is saying, so what I'm looking at on a CDC page is the schedule for, it is saying an mRNA COVID vaccine is preferred for primary and booster. But if a person wants to receive Janssen COVID vaccine, the schedule is a primary dose and then 1 booster dose at least 2 months or 8 weeks after the primary dose.
Thank you so much.
All right, our next question will be from Jack Schummel.
Hi, this is Jack Schummel with KMVT. My question could be anybody. Spring break, March is coming around. Travel's supposed to increase compared to last year's. How would you describe the safety of traveling around this time, maybe compared to the winter and the holiday season this year? And after that, how should people travel when, it's spring break, people travel in groups and stuff like that, families travel together, college kids travel together. What are some protocols that people should follow?
Great, excellent question, and perfectly timed, Jack, because spring break, like you said, is just around the corner and people need to be thinking about that. I'm going to go back to some of the comments that the director made in the very beginning, that while we are out of crisis standards of care, our cases continue to be very high. If you look across the nation, you'll still see all of the nation still being on CDC's dashboard, very still listed as high community transmission. And so I think our messages back to the public kind of remain the same, that you still need to make sure you get your vaccine and get your booster dose. You need to make sure that you're wearing your face coverings. You need to physically distance. You need to be very cautious and really kind of evaluate your risk that you want to take during spring break. I think with percent positivity rates still, as the director said, 5 times what we want to see them at. Maybe they'll be substantially lower by spring break timeframe, we hope. But still, all the same precautions need to be noted. And I will see if either Dr. Hahn or Dr. Turner want to add anything.
Yeah, I could start. Dr. Turner, a few things. Yeah, I absolutely agree with you, Elke. I think the point to remember, we all want this to be over, but unfortunately, case rates are still high, not only in Idaho, but in places that people might be traveling to. Certainly airlines still have their mask requirements in place. I think those are good things to recall in any public places. And we just urge people not to drop their guard completely. We know you're on vacation, and if it's an outdoor vacation, that's probably being outdoors as much as possible. Being, in places where you're not interacting with a lot of other people is ideal. But we understand that's not possible always when you're traveling. I don't know, Kathy, if you have any additional thoughts.
Thanks, Dr. Hahn. I don't have anything additional. You and Elke covered everything.
Thank you.
Okay, our next question, we'll take a question from Rachel Sun.
Hi, Rachel Sun with the Lewiston Tribune. This question would probably be for Dr. Ball. With at-home tests becoming more prevalent, are current case numbers still considered accurate enough to base public health decisions? And if not, how soon would wastewater treatment become a viable means to measure caseloads statewide?
Thanks, Rachel. And Dr. Ball, I'll let you start, and maybe if Kathy wants to add anything.
Great, thank you, Elke. I think you're correct that Dr. Turner would probably be the better person to talk about the overall case data, but I can give you a general sense. As we've seen the market become a little bit more prevalent for rapid antigen tests that you can take at home, that is where we're seeing the greatest demand for testing, just because it's convenient, it's rapid, and people can make the best decisions without having to wait for 24 or 48 hours to get a PCR result. What that does do, though, is that all of those tests that are taken at home are not required to be reported to the state. So what we're seeing is the general proportion of test results is starting to decline. I'll let Dr. Turner speak to the rates of that, and then I'll kind of address the second half of the question. So the wastewater testing program is designed to kind of give us a sneak peek at the community level of what's going on with the amount of SARS-CoV-2 genetic material in the waste stream. It's very difficult to establish a direct relationship between the quantity of SARS-CoV-2 genetic material in the waste stream and individual case counts. As we were talking about, though, there does generally tend to be a positive correlation. So if you start to see an increase in the amount of genetic material in the waste stream, you start to see increase in reported cases. If we start seeing fewer reported cases, it will be harder to assess what that positive correlation means. But if we do start to see increased gene copy numbers in the waste stream, that's an indication that we may have increased disease burden at the community level. And that can help us, trigger public health messaging or other public health mitigation efforts. But I'll let Dr. Turner talk about the actual details, because she's the one that sees that information.
Thanks, Dr. Ball. It's a great question. And it really boils down to us being flexible and able to pivot as a public health, discipline when the situation is what it is now, which is we knew from the start of the outbreak that there were going to be asymptomatic cases that we would probably not hear about because they would not know they're sick, they would never seek care, they would never seek a test. So we've had all along a sense that there is a proportion of the population that may be infected that we don't know about it in public health. Of course, that is now larger because of at-home testing. We realize that, and what we're moving towards is a model of surveillance that is less about trying to count every single case and trying to get a sense of what's happening in the community so that we can communicate what's happening around you, not necessarily what's happening to an individual person or persons. And this is the kind of surveillance we do for other diseases such as influenza. We certainly do not count every case of influenza that pops up in Idaho every year. We use various sources of data, and we combine those data together to present a picture of what influenza activity looks like in the state and in our communities. And so we're moving towards that sort of model. And like Dr. Ball said, the wastewater surveillance is a great addition to a more of a community-based model than an individual case-based model.
Thank you both.
Okay, our next question from Vinny Del Giudice.
It helps to hit the right button. Okay, thank you very much. This is Vinny Del Giudice at Bloomberg News in Denver. A supply chain question. The blood shortages have been cleared up. Of course, that's nationwide. But how, during the crisis standards of care, have the most basic hospital supplies held up? As you recall, 2 years ago, you couldn't get the basics. But during this surge, how have they held up in Idaho? And for that matter, how about pharmaceuticals? Thank you very much.
Great. Vinny, I can take the first stab at this. So what we're hearing from our hospitals and from our partners at American Red Cross and who supply mostly the southern part of the state and Vitalant that supplies blood to the northern part of the state is that since it's a national issue with the blood supply resources, that they had to move to allocating blood supply and blood product to the hospitals. So the hospitals couldn't necessarily just order their standard. They were being allocated a number based upon the kind of what they're seeing in the nation. As we have been working on a daily basis with the hospitals through our medical operations coordination cells calls, we are having them report on their current supply. And they were sort of reporting in this red, yellow, green pattern to see, it gives an indication of what they're looking at. It was somewhat infrequent that we would hear hospitals saying that their blood supply was in the red, or they might be down to just a very minimal level. But what was very helpful is we had a major hospital share a blood supply protocol for how to preserve blood supply, a conservation protocol that was adopted across the state. And so fortunately, our hospitals responded to that really well, and they took those measures into play and really worked on those conservation measures that helped them manage the allotted blood supply with the types of cases that they were doing and how they were handling their patients. So I think that would be the easiest way to explain that. There's still some, I think, scary times for the hospitals, and very worried about, what if there was some major issue that occurred in the hospital setting. But that was fortunately able to kind of make our way through this last crisis standards of care situation operating in that way. And then pharmaceuticals, I don't have as good of a finger on the pulse of pharmaceuticals across the state. And so I'm going to look to my colleagues to see if they have any additional information. Dr. Hahn, do you have anything?
I would just say we haven't heard, I haven't heard discussion of any particular shortages. So I think that's good news.
Mm-hmm.
And okay, I would just add that when it comes to basic supplies such as PPE, we've been very fortunate that since the very first, when COVID first started, we've not had challenges with those basic supplies such as PPE. And there are a few pharmaceuticals that occasionally get stretched, but we haven't heard any reports, as Dr. Hahn said, that that's caused a disruption in the care that's being given to patients.
Mm-hmm. Yeah,
thank you very much. Have a good day.
You too.
Okay. Rachel Cohen, do you have a question?
Yes, thank you. This is Rachel with Boise State Public Radio. I think this question is for the director. So last month, the governor deployed some National Guard members to assist with primary health because they were facing staffing shortages. And I was wondering if you know if that deployment is still active, but just more generally, what are you hearing from the state's primary care clinics in terms of their capacity right now?
Director?
Thanks. Thank you, Rachel. That's a great question. The major pressure that was on the primary care providers, including primary health, which you named specifically, but broader than that, was really staff being out with COVID. And that caused many of them across the state to limit hours or even close clinics. As you mentioned, the National Guard have been deployed. We'll see how long that deployment is needed at this point. But the primary care providers across the state are starting to report that the number of staff being out is directly correlated to the number of cases we have. And so they're seeing less staff be out now. And that's actually allowed many of them to return to normal hours and or keeping clinics open through the weekend, for example. Really important, because if the primary care clinics are closed, those patients are going to go somewhere, and they're going to go to the hospitals, which are already overstressed. And so we're excited to see the primary care capacity start to return to something close to back to normal. And we will keep the National Guard engaged as long as it's needed to help them continue normal operations.
Okay. There is a question in the chat that I will read. This is from Erin Banks Rusby. So I'm apologies if I've mispronounced your name, from the Idaho Press. It says, last week, Dr. Hahn mentioned ongoing efforts to vaccinate Idahoans who haven't yet had a chance to be vaccinated. Has there been any outreach to churches or religious leaders in Idaho to have conversations and offer information that would help encourage vaccination?
It's a great question. And Dr. Hahn, I'll have Sarah take that.
Thanks, Elke. Yes, we have partners at the local level all around the state, and we have funding available for providers to partner with any kind of local organization, including churches and community-based organizations that would be able to get the word out. So there are several of our partners who are working with faith-based organizations and religious organizations to get the word out and have those community-based advocates and community members advocate and educate about the vaccine and to the, they are trusted voices in the community. So those are who we're working with.
Okay. And we have another question from Audrey Dutton.
Thank you. I think this question is for Dr. Hahn. It's kind of related to the confusion over the Janssen vaccines and immune-compromised folks. The delay in the under 5 vaccines and the data on the efficacy of the Pfizer doses for the older group of kids in that age range, it isn't necessarily increasing the trust that people have in this process to have these sort of confusing messages. What can you tell us about what's going on there, and should we feel reassured that there's no Pfizer vaccine going to be considered, or should this be a moment for us to like pause and reflect on what's going on? Help us understand it.
Sure. Thanks, Audrey. And I'll get Chris, if you want to, Dr. Hahn, excuse me, if you want to go ahead and start, and Sarah, if you had anything to add.
Yeah, thank you, Audrey. I agree with you that, well, two things. First of all, I was concerned that there was as the media outlets kept saying, unprecedented move initially to have the FDA authorize a series of 2 vaccines for which a 3-dose series was anticipated. And that made me a little uncomfortable. It felt a little rushed. And I was actually glad when Pfizer retracted that request, which apparently the FDA had initially asked them to submit the data early. I understand the push and pull between trying to get information out as quickly as possible to try to get kids protected as quickly as possible, but it felt like it was going to be a very difficult message, especially when there was data showing that as I think you alluded to, in some of the ages that didn't seem to be a good strong immune response to the vaccine. So I was not alone, I think, in feeling a little bit relieved when they actually backed off of that. I feel like it felt to me like we were going to stumble out of the gate with this one and never convince parents that the proper safety and efficacy data had been fully reviewed by the FDA and their advisory committee and then looked at by CDC, because that data just wasn't ready yet. I have to rely on what I'm hearing through, as far as the insider view. Dr. Scott Gottlieb, that you may recognize his name, he was previous commissioner of the FDA, and he's now on the board of Pfizer, and he's given some interviews in which he has stated that there is no safety concern that's been identified, that they just want to collect all the data and have it all together. And I have to until we see the data. Obviously, we don't know for sure, but I do think that it was actually a wise decision to slow down and let's get all the data together. These are parents of very young children and providers taking care of young children, and they want to have the full data at their fingertips. So I actually thought it was a good move, but I agree with you. I think it was a confusing message, and I just hope when the data does come out that it's clear, well presented, transparent, and that parents and providers have confidence in the vaccine when it is hopefully eventually authorized by the FDA.
Thank you very much. Yeah, as a parent of a soon-to-be 4-year-old, it's been it was an odd experience. I have one other quick question. I don't know if anyone else is in line, but do you have any idea when we might get the kind of Omicron tailored boosters?
Dr. Hahn, do you have any, or Sarah?
Yeah, I'll start, and Sarah may have additional information. The last thing I saw was an indication that vaccine manufacturers were backing off of a Omicron-specific vaccine. Absolutely, they started going in that direction because we didn't know what was going to happen. But I think now with the Omicron wave appearing to subside and we don't know what's next, I think they're focusing their energies on more broad-based vaccines, hopefully a universal vaccine that would cover all the variants. So that's my current understanding, but Sarah may have heard something through her channels different than that.
I have nothing to add, Dr. Hahn.
Okay.
Thank you.
Our next question from Ian Stevenson. Apologies, I believe I missed your hand a little bit ago.
No problem. Thanks, Greg. Ian from the Idaho Statesman. I was wondering whether someone could talk a bit more about the situation with intensive care unit patients at the moment. Since roughly early February, looking at your data, it looks like the overall number of hospitalized patients is decreasing, but the number of intensive care patients is increasing a little bit. Is that divergence something? Does that reflect the trend that was seen during previous surges, or is something distinct happening with Omicron, or anything else of note there?
Great, thanks, Ian. And Dr. Turner, do you want to address that question?
Yep, I can try. Thanks, Elke. Ian, the average length of stay for a person who ends up in the intensive care unit tends to be a little bit longer than a person who is hospitalized but doesn't go into intensive care. So while we'll start to see the total census of people who are hospitalized starting to go down, the census of ICU patients may either stagnate or even go up a little bit until it starts to follow. And it just really has to do with the length of stay that on average, it's, there might, individual cases might be different, but on average, that difference that we see with hospitalized versus someone who's in the ICU. And that's probably what you're seeing in the data.
Thanks.
I'm giving a quick scan for additional reporter questions. Please raise your hand if you've got anything, or we're going to move toward conclusion.
Greg, I'm sorry, I sent you a chat, but did you see there was a question in the Q&A?
Sorry, I do not see it. Oh.
I can read it, right? I don't know if the reporter.
Please go ahead, Dr. Hahn.
Okay. Sorry. I saw it. I know we usually look in the chat, and but there was one in the Q&A, and let's see if I can open it up. Anyway, it was essentially asking about the that some school districts are starting to drop the mask mandates. Now we have Boise School District that just said, yes, we're going to drop it, but not until after spring break, and kind of our reactions to that. And if I got that question wrong, I think it was Channel 6 that asked the question. I'm sorry, I'm not.
Yes, it was from Madison Hardy from Idaho News 6, and that was you've captured the question, Dr. Hahn.
Well, Dr. Hahn, would you like to go ahead and address the question?
Yeah, sure. Yeah, I'm happy to. Yes, we've been watching this, of course, very carefully. We understand that parents, schools, a lot of people are eager, children are very eager to have the mask mandates go away. I think we are worried about the fact that there is still a lot of disease out there. We don't want to see cases spike again. I actually thought Boise school districts came to a wise decision last night to say, yes, we want to move in that direction. We want to have a spring, hopefully without mandatory masks, but would like to wait till after spring break. But time will tell what the right decision was. Of course, even without mask mandates, individual teachers and school employees and children may continue to wear masks. And we have a lot better masks available now than we used to that can offer personal protection. You know, the KN95s or N95s we didn't have those available to the general public really when we started this whole outbreak. So I'm hopeful that for parents or individuals that are concerned that they can have that as a tool. The director announced earlier that we have the giveaway of these types of masks for individuals. So hopefully that will give reassurance to those people who are not ready for that.
Okay, thank you for the question, Madison. Sorry, I didn't see it. Okay, another quick scan for hands. Seeing none, we're going to wrap up for today. We are going to return to hosting COVID-19 media briefings every other week until further notice. So our next media briefing will be Tuesday, March 1st at 2:30 p.m. We'll issue a news release with a specific announcement and invitation. So watch for that in a couple of weeks, and we'll see you all then. Thank you.